Morning, everyone. Good morning, everyone, and welcome to another version of the Internal Medicine Grand Rounds. Today, we have a wonderful update on breast cancer genetics from Dr. Brian Dong. And to introduce him properly, I am going to introduce his section chief. That is Dr. Beth Riley. Elizabeth Riley is a professor of medicine, and she's our deputy director of health affairs for the Brown Cancer Center. She is, as I mentioned, section chief in medical oncology and as well as benign hematology. And she's the director of the breast cancer multidisciplinary clinic. She's a native of Louisville and grew up in Kentucky and went to medical school here. And she did her residency all the way over in Boston at the BI, Beth Israel Deaconess Medical Center, and her oncology fellowship was there as well before being recruited back to here and working her way up to professor with a stellar performance that we've come to rely on. And so, Dr. Riley, please take it away.
Thanks, Dr. Williams. So it's my pleasure to introduce Dr. Brian Dong. He's an assistant professor of medicine in the Division of Hematology Oncology and director of our high-risk breast program. He's also a member of our Oncology Safety Committee and has a specific interest in high-quality care. So he's a homegrown success story that I'm really proud to be working alongside. So he is a triple UofL, med school, residency, fellowship, all at UofL. And truly, Brian is beloved by staff, colleagues, and me, and most importantly, patients. He's really making impact in the short time that he's been here. He's growing our breast cancer trials program. He's a faculty member on the Move to Watch, and so I'm happy to introduce him to talk about breast cancer genetics and high-risk breast disease.
All right, thank you, Dr. Riley. Yeah, I probably should get myself on the move a little bit more too, but I'm excited to give you guys this talk this morning. So I called it very generally just kind of an update in high-risk disease and genetics. But truthfully, my goal is to kind of give you an idea of what a clinic visit is like with me and women who want to know what their risk of breast cancer is, and people that are proactive in things on either reducing their risk or trying to catch it as soon as possible. So in terms of, there's a national movement to, improve cancer survival. And the easiest way to do that is to diagnose people earlier than with later stage disease. So a big part of what I do here is helping women, with that. So, so Dr. Riley already mentioned, so I just put this up here just for fun, really. And, clearly I've been here a while. I've been scrolling through the participant list. I think I know probably 80% of you all. So if I called you with late night consults, I apologize, but hopefully this will be, laid back kind of just overview here. So here are some disclosures of mine just in terms of clinical trial work, and then also some advisory work as well. Okay, so like I said, the general outline, I'm going to give you a couple case scenarios at the beginning that are very common what I see on a regular basis, and then talk about the factors and who is high risk, right? Everybody has a family history. You write down non-contributory, you write down heart disease or whatever. But when you hear things like breast cancer, ovarian cancer, prostate cancer, if you hear it more than once, it should start to ring a bell. And then there are follow-up questions to ask that can potentially have implications for the patient and their entire family. And then I'll talk a little bit about high-risk genetic syndromes, and as well as some of our statistics here at the Brown Cancer Center. Okay, so I'm going to go through these kind of quickly. So let's say you have a 34-year-old female, so a very young person, that's motivated because her mother had breast cancer at the age of 68. All she knows is that she was treated with a mastectomy and did get some, hormone therapy afterwards. She has no acute complaints, and on exam, she has a normal breast exam. So if I'm seeing her, does she need genetic testing? When should she start mammograms, right? She's only 34. Does she need MRIs of her breast? And then does she need prophylactic or preemptive risk reduction anti-estrogen therapy? So these are the kind of questions that commonly come up, and they're not short discussions, as you can imagine. But are needed for a lot of women. And then what if you change your family history? What if you add a maternal aunt that also had breast cancer, but in her 60s? And then what if that aunt had a niece that also developed breast cancer? So you can see how there's a lot of permutations. And I've seen even people with 10 family members that have had, hello, Dr. Kumar. So, anyway, the family history obviously can be fairly extensive. Another case here is a slightly older female, but still very young, 45-year-old woman with heterogeneously dense breast tissue on her first screening mammogram. Sees a focal asymmetry in the right breast. She gets a diagnostic mammogram and ultrasound. It shows a small mass measuring about 6 millimeters. You do a biopsy that shows atypical ductal hyperplasia, but no invasive or in situ disease. She has no family history of any breast cancer, and she was asymptomatic when she had her first screening mammogram. And no, she's premenopausal. So the question is, what do you do with this? It's not cancer, but do we need to cut this out? Does she need additional therapy? Does she need additional screening? So this is also a very common visit for me. And then the last case here is an even younger woman at 25 years old, but her mother just tested positive for BRCA1. Her mother maybe saw someone, let's say, in a different state, was recommended testing and found something. So she comes to see me, we order testing, and she's BRCA1 mutated as well, but she's only 25. So the question is, when do you start screening on her? Does she need MRIs? You hear BRCA, you think about the surgeries, and then same thing with the anti-estrogen therapy. So you see there's kind of a theme here in terms of being proactive with screening and then considering things for risk reduction. Okay, so before I go into high-risk disease, we should do a quick overview of benign disease. So certainly, this is something that I think everyone's probably familiar with. I think they like to ask these on shelf exams and maybe some ITs in terms of, fibroadenoma, fibrocystic change. Certainly, the main buzzword is waxing and waning size of the menstrual cycle for fibrocystic change. And then fibroadenomas are completely benign, but sometimes we will excise them if they become symptomatic enough, but they're certainly not cancerous in any way. And then, some of these other things, like I said, just to be kind of thorough there, fat necrosis after trauma sometimes shows up on one of the shelves I think I took, I don't know, 12 years ago or something. And then just kind of a quick overview here of the screening guidelines from the USPSTF and then the ACS. So, of course, American Cancer Society will be, I don't know if aggressive is the right word, but certainly more vigilant in screening. So, so they say, if you have a family history, to consider starting at 40, but certainly start at 45, whereas the counterpart and the USPSTF says starting at 50, and they say every 2 years. My 2 cents on this is I see women on both sides of the spectrum, women that are high risk, that don't have active disease, and women that have metastatic disease that we are just trying to palliate. A mammogram, once again, I'm aware that I'm a man saying this, but a mammogram is a relatively quick study, maybe not harmless, but certainly not as involved as a biopsy, chemotherapy, surgery, things like that. So certainly I would support more so the American Cancer Society guidelines, but I understand, the general population, I think both of these are still, worth the discussion and reasonable. Okay, so like I said, I'm going to try and, the next 30, 40 minutes or so, give you an idea of what a visit is like with me in the clinic. Essentially, there's 2 halves. So the first half is if they need genetic testing or not. So we'll dig into the family history. Sometimes patients have had other family members that have been tested. I get questions a lot about, well, how much is it going to cost me? Is it going to mess up my insurance? And those are completely fair questions and nothing you think about until you're attending and have to deal with these things. And then in terms on the other side, well, what do we need to change going forward? Do you need any kind of surgery? Do you need more screening? Are there lifestyle modifications we can make? And then I'll talk about the therapeutic as well. So I'd like to start with the risk factors first. So once again, just kind of broad overview here. Sometimes a question pops up of like someone that had Hodgkin's lymphoma in the chest, they got, 30-degree radiation or something. So that is something you should pay attention to. If you see that in a question stem, they're probably leading you towards breast cancer. So that is a big risk factor. Anything that prolongs estrogen exposure. So early onset of menses, late onset of menopause, nulliparity certainly are general risk factors as well. And then I'll talk a little bit about alcohol use and diet and things like that a little bit later too. So one of the main takeaways I want to give you guys is as you see people, whether it's in the hospital, in your clinics, to have more of a screening for kind of identifying who's high risk. Right now, a lot of it happens when they come in for their mammograms and then the breast radiologist says, oh, you have dense breast tissue. And oh, your mom also had breast cancer. That sounds kind of funny. Maybe we should look into this a little more. And then that's how a lot of my referrals happen. But truthfully, there are a lot of women that I see with an already having a cancer diagnosis, and maybe they have ADH, or maybe they had a significant family history that they just, either ignored or didn't want to be proactive about. And, now they're coming to me with advanced disease. So very generally here, I mentioned the thoracic radiation as a risk factor. Obviously, if you have a pathogenic genetic mutation, that's a risk factor, although most women don't know until they know kind of thing, right? So someone has to do the testing. Atypia, which I'll talk about in a second, can certainly increase your risk. And then Tiracusic is a breast cancer risk model I'll talk about here in a little bit. Okay, so very quickly, I just wanted to overview atypia. So oftentimes, all the residents in the clinic and everything, they're get your screening colonoscopy, get your screening mammograms, pathogens, all those kinds of things. And commonly, screening mammograms will lead down a path of something abnormal. They have to do a diagnostic ultrasound biopsy. And sometimes you'll get a result that shows atypia. So the most common types would be the two here, atypical ductal hyperplasia and atypical lobular hyperplasia. So these in themselves are not cancer. They won't turn into cancer. They're just abnormal tissue that person developed. The issue with these is that women that develop atypia are more likely to develop a new lesion that is cancerous in the future. So that is why we call these high risk. On top of that, oftentimes these are found at the same time as invasive disease. So I've kind of listed a little number here and it is a bit of a range depending on the data analysis you look at. But when you see ADH, oftentimes it can be associated with DCIS or invasive disease. It just depends on the biopsy, right? It's if you don't get the perfect sample with the needle, then you may only catch the ADH component. So about 20% of the time, we'll find invasive disease at time of lumpectomy. And I would tell you the range in this number is quite high. So I've seen as low as 10 to 12%, but I've seen as high as 40%, depending on the database and what part of the world you're looking at. And so it's a similar idea with atypical lobular hyperplasia, but the risk is slightly less than ADH. However, in terms of resection, most of these are a discussion between me and the breast surgeon, Dr. Aikai, and the breast radiologist as well. And then one more quick note on LCIS. So once again, this in itself is very different than DCIS. I'm sure you guys remember, the charts from, your MS2, MS3 years maybe. This again won't turn into cancer. However, they did a really nice database analysis where they found that women with LCIS had a match of about 1% risk a year over a 20-year period. So at 10 years, 11.3% of the women had breast cancer. And then at 20 years, 19.8 or essentially 20% also had breast cancer. So when you see these women, certainly, they should be referred to a high-risk clinic. You don't absolutely have to cut these out. It just depends on how it was discovered. So if it's associated with a mass, these rarely form a mass. So you should probably consider resection. I won't talk too much more on that. It's a little nuanced, but essentially it's a discussion between the surgeon and myself and the radiologist. Okay, so if you see atypia, hopefully that sticks as something unusual, maybe not cancerous, but certainly increases the risk. In terms of these models or standardized kind of risk calculators, there's a few. The Gale model is the oldest one, and that's kind of morphed into the BRCA Pro. I personally prefer the Tiracusic. So several of these are in our National Cancer Center guidelines. And I'm actually going to walk you through what the Tiracusic kind of looks like. And this is overwhelming slide, but essentially if you just stick to the left side, I mentioned the thoracic radiation, and then they list residual lifetime risk greater than 20% as defined by model. So those are the models I just showed you. And essentially, if you do qualify, that is kind of the benchmark for high risk versus not. And then obviously there are implications in terms of screen. So, the right-hand side, don't worry as much, but the 20% is a very important number. Okay, so this seems silly, but I will do this in the room with the patient, and I will say, look, if, and being an oncologist, friends from med school or friends in life, people always ask like, hey, my family member has something, or hey, I'm worried about my risk. And I always just say, if you're worried about something related to breast cancer, just Google Tiracusic. And literally, if you Google it, is why snapshot. And I guess I did it recently. That's why I registered the vote thing there. But it's literally the first result. So if you someone that's concerned, or you want to see what it looks like, you just Google it right there. So I took a couple screenshots here. I just kind of filled in some I try to make it just a young woman without many risk factors at the start. I don't know why I forgot to put no verse here, but let's say, it's a 42-year-old woman. I think it's 42, sorry, the screen's broken with it, but 42-year-old woman that is not in menopause yet. She's never been on hormone replacement therapy. And you can kind of see how it's very simple to just go through the list here. They asked about genetic testing. If they've had breast biopsies before. So in this 42-year-old, I did give her a check for atypical hyperplasia. Let's just say ADH, like I mentioned a few slides ago. And in terms of family history, she's not of Ashkenazi Jewish inheritance, but I did give her a grandmother with breast cancer, let's say in her 70s, but she did not have genetic testing. There's one more component I didn't show, which is breast density, but I'll talk about that in a little bit. So when you put all this information in, it'll give you several sets of data where essentially there's a 10-year risk and then a lifetime risk. So let's see what that shows. So if you focus on the top left here first, this is with the maternal grandmother and the ADH. If you look at her lifetime risk, it's 35.8%. And the average woman her age is about 10.6 according to this calculator. So with the atypia, it's about 3 times higher, which is very interesting. And then if you look at the 10-year risk, it's 7.5% versus 1.9. Well, let's take away the ADH or the atypia, and it's just the maternal grandmother. Now it goes to just a slightly increased risk, but not severely increased. So she wouldn't meet that criteria, 20%. And then if you take away the atypia and the grandmother history, well, now she's actually below average. So it's a nice exercise in terms of identifying the risk increase for each of these things. So certainly, hopefully this also helps further hammer home that atypia is a very high risk setting. And then I don't know if I say this on another slide, but I want to point out here as well, the 10-year risk is also very important. Women who have a 10-year risk over 5% benefit from risk reduction anti-estrogen therapy. And my short spiel on that is essentially 70 to 75% of breast cancers are going to be hormone positive or estrogen driven. So in a high-risk population, that's the most likely breast cancer they're going to develop. So if we reduce their estrogen exposure for a 5-year period, then we can either push back or prevent a future breast cancer. And I'll show you some data in a little bit that helps support that. Okay, I did put on a slide. So once again, so there are 2 main cutoffs: are 10-year risk 5%, lifetime risk 20%. And then, with no risk factors, the average woman has an average risk of breast cancer somewhere between 10 and 12%. So, that is kind of intimidating to think about, even with no risk factors. So certainly if you add risk factors, it can certainly escalate very quickly. Okay. So there's a lot of text here, but basically I just want to say, when we determine a plan after a first consultation, the question is, we start with annual mammograms. Do we need to do more? At the very minimum, usually I recommend clinical breast exams with me every 6 months, and then self breast exams every month. If your tiracusic is over 20%, then we'll recommend MRI breasts in addition. And what I'll try to do is stagger them, so it's every 6 months you're getting some time of imaging, so that we can reduce the lead time bias if you're going to develop a breast cancer. So for example, and I'm not the best of months, if January you got your screening mammogram, in July, July, you would get your MRI breast. And we would just keep that schedule roughly for the entirety of the time that we decide to screen. And then in terms of endocrine therapy, like I said, so and when I say endocrine, I mean anti-estrogen therapy, so endocrine blocking therapy. That's that 5% bar. And I would tell you, it's sometimes hard to convince women that have had breast cancer to take estrogen blocking therapy. So in this population of women without cancer, it is even more of a challenge. And with that said, of all these things listed here, the endocrine therapy is the only thing that will actually reduce your risk. The other thing is just, reduce your lead time bias. So these are conversations I have pretty regularly, and I would tell you, it kind of just depends on the patient. And I feel my job is just to educate them the best I can and let them make a decision for themselves. Okay. So these are a few of the larger trials looking at risk reduction anti-estrogen therapy. And I'll tell you, there's somewhat data now, but that's because they had a long time of monitoring. So it took many years to find these to get the data. So the IBS-1 trial was over 7,000 women, and it was mostly European and Scandinavian kind of area. And they basically said, hey, these genetic clinics, these high-risk clinics, we want to enroll all your patients and decide and put some on tamoxifen, some not. And they followed them for, I believe, was it 16 years. And you're going to look at this difference and say, well, it's only it's less than 3%. But they only fought. A lot of these women were younger, and maybe they weren't going to get a breast cancer until their 60s or 70s. So if they kept following, maybe we would have found more events, so to speak. However, this difference was still significant. And like I said, it's a heterogeneous population across multiple countries. For some reason, they used a tiracusic cutoff of 8%, which was kind of weird, and 82% of them were less than that. So it's a very mixed group. If someone had 2 family members with breast cancer but negative genetics, they were included in the study. So then they said, let's do a follow-up. Let's look at postmenopausal patients. Let's use aromatase inhibitors, so anastrozole versus placebo. And they kind of broke it down by tier. If you're younger, then you need to be double the general population risk. If you're older, you can be up to, you can be even higher. And what they found was a more dramatic difference. So when they followed these patients for, I think it was it 10, 11 years or so, they found that there's a relative risk reduction of almost 50%. So certainly that feels a little bit more impactful and a little bit more to justify, the medication to the patients. And interestingly, the adherence to placebo and AI were both fairly similar. And then more recently, in 2019, or I guess maybe not that recent, but there's a publication actually looking at low dose tamoxifen, only 5 milligrams, when the normal dose used is 20 milligrams. And they found that even at that dose, it was better tolerated, and there was a reduction in events. Now, granted, this is a much, much smaller population, shorter follow-up, but still can support if someone is motivated, but they can't tolerate the higher dose, to consider cutting it all the way down to 5 milligrams, that there's still some benefit. Okay, so I really hope my breast radiologist is not listening to this, but I'm going to do my best here. So breast density is also very important. And this is the photo I love to show patients, where essentially you get a bit of a spectrum here in terms of fatty breast tissue all the way to extremely dense breast tissue. So hopefully the difference here on the ends is pretty dramatic. At the end of the day, mammogram is just an X-ray of breast tissue. And the more transparent it is, the more easily you're going to be able to identify abnormalities. At scattered, you can start to see some thickening of some of the stroma here. And then I know it looks like a major change between scattered and heterogeneously dense. I will tell you it's not quite as pronounced as shown in these two photos, but more of the breast will be involved. In some areas may be very dense. And then if you look at extremely dense, it's almost opaque. And the idea is if there is a mass to form in the middle, I don't know if you see the mouse, but somewhere in the middle of this very dense cloud on the dense tissue on the right, it's going to be much harder to identify on a mammogram, so that we may catch it much, much later when it's grown to a size where now it becomes, I'll use the word obvious, but more clinically significant. So in these cases, you probably get where I'm going with this. We consider MRI breast. So MRI breast, the silly analogy I use is when you go to Costco or Best Buy, they have like 50 TVs up, and then there's one really, really big fancy TV that is either front and center or it's like, really high up on some feature platform or whatever. That's the MRI breast for us. And this is a very, once again, kind of dramatic example, but this thickening here that you see in the breast is the dense breast tissue. And theoretically, a mammogram could potentially miss this large mass on the posterior, whereas an MRI it looks clear as day. So this is another picture I'll show patients just to show, we get higher quality photos, and hopefully helps motivate them to say this is a test I'm willing to get done. So once again, this is a little obvious. There are obviously more subtle changes that we can identify too, but I think it helps drive the point home on the utility of these. And then in terms of lifestyle risk reduction, so you'll notice that none of these were in the Tiracusic calculator. However, when they look at retrospective data analysis, there are certainly trends or correlations where I think there is some significance to this data. So when they look at women that drink heavily, it kind of correlates to where if you drink 2 drinks a day, then you have higher risk than someone that drinks none. If it's 3 drinks, it's even higher. If it's 4 drinks, it's even higher than that. And I think, I don't know if it's as simple as just attributing it to 1 extra 12-ounce beer, but I think it probably is just the overall reflection of maybe the lifestyle and health and maybe willingness to even go get a mammogram. Same thing with exercise. When they look at kind of women that are more active, they're less likely to have breast cancer than women that are less active. And once again, is this due to just being healthier, more likely to get screening, reduce body fat content, maybe more reliable self-exams? They're more likely to notice something if it's smaller, abnormality. I don't think it's quite clear, but it's an interesting correlation. And they kind of all on the same lines with obesity. If they compare women with BMI less than 21, they have less cancer risk compared to women greater than 31. So, these visits, obviously I'll recommend, balanced diet, regular exercise, but in terms of data, it's like I said, it's more correlational. So it's kind of just general good advice that, I probably listen to more in terms of exercise. So, but it does, it's something that I'll address at every visit. Okay, so let's go back to a couple of the cases. So in the first one, 34-year-old woman with just the mother with breast cancer, she actually does not qualify for genetics. And I guess I kind of mistimed this. I'll talk about genetic indications in a second here. In terms of when to start mammograms, I would say she should consider at 40, but certainly by 45. If someone were to contradict me and say 50, that's not necessarily wrong, but I would push for 45, maybe 40. And in terms of risk reduction anti-estrogen therapy, I didn't do the Tiracusic for her, But if you can think back to when you take away the atypia, just the grandmother, certainly that person did not qualify. So I would not expect her to qualify. However, if you add in 2 more family members with breast cancer, then that's going to change things completely. And I would fully expect her therapeutic to reflect that as well. And then in terms of the ADH case, so for genetics, you don't need to do it for ADH alone. In terms of management, so I would absolutely refer this person to a breast surgeon. I would do the therapeutic calculation. She's premenopausal with atypia, would almost certainly be high risk. So in this case, I would recommend MRI breast and supplementing annual mammograms. And I would be surprised if her 10-year risk wasn't above 5%. So this would definitely be a discussion on, in her case, tamoxifen for risk reduction in the future. And once again, if she didn't tolerate it well, we could consider the lower dose at 5 milligrams. Okay, so let's shift to genetics. I apologize, Meredith, if you're watching. I blew up your photo from your website page. So we recently, not recently, I think last year or so, we hired Meredith to be our geneticist, and she's done a fantastic job. So she is kind of our backbone mainstay here in terms of getting testing done here at the Brown Cancer Center, following these patients, updating them with full counseling, as opposed to outsourcing to some company that calls patients, sometimes. It's been my prior experience. So I'll talk a little bit about the high-risk mutations, who needs to get tested, what kind of changes in management there are, cover the costs, and then show you some of the statistics of our cancer center here. Okay, so overwhelming slide here, I apologize, but essentially these are in our guidelines as well. The top half is for a woman with cancer, and then the bottom half is for essentially if you don't have cancer, but it's a family history. Essentially, I would just say there's a couple indications. One, if you are premenopausal or of young age at diagnosis, you absolutely need it. Or if you have a family history of someone that was diagnosed at a young age, then that child also needs it. And then if you're triple negative, once again, those also qualify. And truthfully, in about 5-10 years or so, I think we'll be doing genetic testing on all breast cancer patients. Truthfully, I think right now it's mostly probably an insurance holdup, so to say. And then if you look over here on the right, so this is also interesting. If you have 3 total diagnoses of breast cancer, so maybe your grandmother had recurrent disease, and then there was another aunt or something. And then if you have 2 close blood relatives with breast or prostate, and I'll actually even throw in ovarian cancer, those patients also qualify. So if you're not in the top half, you're a family member down here, you basically add 1, because then it has to be their mom, their aunt, or something like that. So when you follow these guidelines, we have very good success in getting testing covered. But I want to show this that there is a general outline for testing. And also to point out, if you're Ashkenazi Jewish ancestry at all, then you do meet criteria as well. Okay, so this is not the most, it's a little pixelated, but we currently are using Ambry Genetics. I just wanted to show you kind of the genetic panels that we will check for. So yes, there's a BRCA1 and 2 box. It's on a different page, but that is really the bare minimum. Patients about, I would say maybe 5 to 10 years ago that were going to these high-risk clinics, most of them were getting screened just for BRCA1, BRCA2. And that is not up to date with modern genetics anymore. As you can see here, there's a few BRCA, BRCA pluses, BRCA next, BRCA expanded, and then also this cancer next. And you notice obviously BRCA1 and 2 are there, but then there are other several high-risk genes, and some of them, the list gets up to 23, 36. And I will go through actually a few of these here in just a second. But before that, I'll talk a little more in detail about BRCA. So certainly this is, I always reference Angelina Jolie, and I think Christina Applegate. A lot of patients are familiar with this. And sometimes they'll say, oh, I was tested for BRCA, I think I'm good. But then they were only tested for those. So as you guys know, this is a tumor suppressor gene involved with DNA repair. If you have a mutation in this, you get less repair mutation. So then you have increased instability and break in your DNA. The lifetime risk for breast cancer, these will vary depending on the study you're looking at. I've seen as high as 80%, 90%, but generally for sure over 50%, somewhere in the 55 to I would say maybe 80% range. And then BRCA2 also elevated. It's important to remember that it's not just breast cancer. You have to worry about ovarian cancer, pancreatic cancer, and also melanoma. And then in the men as well, it's important for them. Does my brother need to get tested? Does my son need to get tested? The answer is absolutely, because there's a risk for prostate cancer as well. And this is a slide I like to show, just to show you that it's more complicated than just BRCA1 and 2, right? There's several cofactors, And certainly in people with active disease, with metastatic disease, there are treatment implications for mutations in many of these genes here, including these Fanconi anemia core complex, which I'm not going to go into detail today, but these are things that we routinely do for breast cancer, for ovarian cancer, for pancreatic cancer, and even prostate cancer. So these are certainly an active area of research, and I just like to show this just for complexity purposes. Okay, so in terms of management, you should consider bilateral salpingo oophorectomy after childbearing is complete, around the 35 to 40-ish age range. Truthfully, anyone that I see, I will refer to gynecology, oncology, just to have the discussion. And then prophylactic bilateral mastectomy is recommended, but obviously this is a patient-dependent decision. Some may not want to offer this, some may want it immediately. It's like I said, it's a discussion. If they choose for a non-operative route, then certainly should consider utilizing MRI breasts to start around 25 or even 30, depending on the age of diagnosis of any breast cancer in the family. And then once again, like I mentioned earlier, I would consider staggering with mammograms every 6 months. Anti-estrogen therapy should be considered, but I don't think, well, I guess I'll do it in the case in a second, but I wouldn't necessarily start it the second they get diagnosed. If someone's 25, 30, they may not actually get benefit from it. You can probably hold off until much later. And then in terms of the other cancers, I say no different screenings, but really they need to have these discussions with a different specialist, like the gynecology oncologist. Okay, so this part feels a little dry to me, so I'm going to go through these pretty quickly. What I will say is that for every one of these mutations I'm about to show you, I have patients with these mutations that I'm following in the clinic, except for one, which is the first one, Li-Fra-Mini. So TP53 is a very common mutation we'll see in pretty much all cancer types. However, to see a germline TP53 mutation is actually a little bit rare. However, my teaching point of this is basically if you have a family history where it's like every cancer, you're like, oh my goodness, this is so many random cancers. For example, CNS disease, sarcoma, leukemias, this is what you should think about. And in these people, so breast is also included, and I would absolutely consider MRI breast in addition to screening. And mastectomy, I wouldn't jump to unless they had a very significant family history of breast specifically. For hereditary diffuse gastric syndrome, so this is one, at least on the oncology side, I've seen on our tests a lot. So I don't know this to be on medicine boards, but it's in the cadherin-1 gene. And essentially the association you have to remember is gastric cancer and lobular breast cancer. It's a very unique association. And the most recent patient I saw with this actually had both, unfortunately. Cowden syndrome, or also called P10 hamartoma syndrome. It's similar to Peutz-Jeghers. You have to think about hamartomas in all tissues. For Peutz-Jeghers, it's only in the GI tract. So sometimes they can have CNS hamartomas, breast, GI, soft tissue, very diffusely present. And they're at extremely high risk for breast cancer as well. So they should be offered mastectomy versus MRIs and mammograms. PALB2 is another very high-risk pathogenic mutation. It's essentially a cofactor for BRCA. So involved once again directly with DNA repair, and the breast cancer risk mirrors that very closely at BRCA 1 and 2. So essentially for these patients, we treat almost similarly to a BRCA mutation. And then I think this is the last slide. So Lynch syndrome is an interesting one. So this is something that's very common in Kentucky. And normally you think about associated with colon cancer, metastatic colon cancer. These are patients that respond better to immunotherapy. I would say a general recommendation is that these aren't necessarily associated with increased risk of breast cancer. However, they're starting to identify maybe patients with PMS2 and very small subset analyses that these patients actually are at increased risk. So I wouldn't recommend necessarily mastectomy, but certainly I think they should be followed by me, and it's going to be kind of a patient by patient decision on exactly what their plan would be. Once again, family risk factors, breast density, things like that. But I did want to put it here because I do think is worth considering. And I've actually had a couple recently that were with Lynch syndrome, know about the colon cancer risk, but had family history for breast cancer. And we've increased their screening. CHEK2 and ATM, in my mind, are somewhat similar because there's a risk of breast and I believe ovarian for both. CHEK2 has a colon cancer risk as well. But once again, these are on the 8 gene panel that you saw earlier on that pixelated screen. But these, I would say, are the bare minimum of genetic mutations I would look for today in someone that qualifies genetic testing that probably wasn't tested in 10 years ago or so. Okay, and I forgot I wrote this slide too. So essentially, in women that I've been seeing with known BRCA1 and 2 mutational testing that was negative, I will recommend repeat testing for at least an 8-gene extended panel, potentially even more. And if you talk to the genetic companies, they will tell you if it was 5 years ago, then it was outdated. So I know that can be kind of concerning to some patients to hear, but this is an evolving thing, right? So, every year we're learning more about cancer formation, but also risk factors as well. There are mutations that we call VUS, variant of uncertain significance, that can transform either into being something pathogenic or not, depending on patients with these known mutations that they follow. So this is an evolving thing, and certainly being plugged in with a high-risk clinic is very helpful for a lot of these patients. So just, I guess, to conclude, go back to the BRCA case here. So she's 25, but I think I've added maybe the grandmother here was diagnosed at 38. So I would consider starting screening 10 years before that. So at 28, I would do mammograms and then probably come in with MRIs around 30. I think I had a slide earlier, they can consider 25. It really depends on how motivated the patient is. In terms of when to have surgery, mastectomies are certainly dependent on the patient. For the oophorectomies, I would say it depends on their family planning, and maybe family history if someone else had ovarian cancer at a young age. But certainly I would plug them in with the breast surgeon and then also with gynecology and oncology. And in terms of anti-estrogen therapy, this is once again, a discussion. But important thing to note is the average age of breast cancer diagnosis in the average population is around 62. But when you look in patients with BRCA, it's about 42. So you don't want to hold off too long and then lose the benefit that you may get from it. So you certainly want to be mindful of that in these discussions. I think I'm doing okay on time. So this is a snapshot from the counseling part of our Ambry genetics form if you're found to have a BRCA mutation. So this just kind of shows kind of what I just mentioned on the last slide, when to come in with MRI, when to start clinical breast exams, things like that. Okay, so I wanted to end here with some of the statistics here at the Brown Cancer Center. I thought these are pretty interesting. So these are in 2021, and you can see kind of the breakdown of genetic testing here. And this was with their old company, Invitae. And I'll just point out for myself, this is only with 6 months of me. So, Dr. Riley, I'm coming for you, and ICAI maybe I'll surpass you too. But certainly we did a fair amount of testing here. And when you look at our positivity rate, it's actually 12.6%, which is, in my mind, actually a pretty high number. You may say only 52 people, but these are patients with high-risk mutations that are going to require potentially risk reduction surgeries, increased screening, and also extended family testing as well. And I guess I should mention, if you were found to have a positive test, the genetic companies will cover testing for the entire family, the immediate family. And they'll essentially just test for the one significant pathogenic mutation. So we have Meredith, like I mentioned earlier, who assists us with these, and they will send testing kits across the country to other countries. You essentially just need a provider to sign off on the form and send the testing kit back to the central company. So in this case, either Invitae or Ambry or Natera, or Myriad, there's plenty of companies out there. And then I think this is one of my last slides. I wanted to drive this point home in terms of cost. Anytime I bring up genetics, the number one thing I get asked is how much is this going to cost? And I think about 5 or 10 years ago, the answer was probably like $2,000–3,000, something very, very high. But I want to show you here that at least in 2021, 80% of our patients paid $0 out of their pocket. If you meet the criteria, we're a high volume center for ordering genetics. We can get these covered the vast majority of the time. And then if you look here at the bottom, really the maximum charge that a patient should get is about $250. And if they're going to charge you this for an insurance reason or whatever, they usually will call the patient, get consent. Are you okay with us charging you $100 or $250? And the patient has to okay it before they will, complete the testing. So there's pretty good transparency, I think, in terms of cost and testing. And I will tell you, I'm not sure the experience would be the same if you go to an OB or PCP. Truthfully, I'm not as familiar. But certainly with us, like I said, being a high volume center and having a good relationship with these companies, we can fight pretty well to have our patients pay as low cost as possible. So hopefully that's interesting to see. My goal is to keep that number around 80%. And if we fall for some reason, then, we need to, keep a close eye on this. Okay, yeah, so to conclude here, in terms of identifying patients with high risk breast cancer, be mindful when you see atypia on a breast biopsy in one of your patients. There is something called this tiracusic that I would hammer home again as, if anyone you're seeing is worried about their risk, just Google it. First result is right there. And in terms of genetic testing, I kind of try to summarize that overwhelming slide earlier. They have a family history of triple negative breast cancer at a young age, or multiple family members with breast, ovarian, or prostate, then they meet criteria as well. And the testing can be affordable for patients if they get it done at the right center. And also just to hammer home that the best high risk care comes from multidisciplinary discussion. So I meet regularly with our breast surgeon and the breast radiologist to discuss these cases, the images, to plan future screening. All right, so I think that's it. So happy to take any questions.
Thank you so much, Dr. Dong. If Dr. Riley will allow, I'll take chair prerogative and, of course, try to talk a little bit about healthcare disparities. So as I understand it, this is one of our major issues where the risk of white and Black women is higher than Hispanic. And so there are ethnicity differences. But the issue with the African-American women is really a serious one in that they present very early and with advanced disease. And so, while folks it seems like everything I read about this is talking about equitable screening mammography strategies. How about genetics? I don't see as much discussion of going into the community and doing genetic testing at an earlier stage. How do you feel like so that's really two questions. What do you think we should be doing about healthcare disparities in breast cancer? And should we, as I'm going out and doing cholesterol and blood pressure screening, should we, collect blood and do breast cancer genetics?
Yeah, I mean, absolutely. So this is a critical thing that I think absolutely needs more focus from just a screening standpoint and then also genetic testing standpoint. And part of it, I think, is absolutely cost. I'm not trying to toot my own horn, but I was on like Wave 3 News or something last year. I was talking to Don G about this, and she literally asked me the question on live TV: why does it cost $5,000 to get genetic testing done? This is the stigma that's out there, right? So I think breaking that down is very important. I think coming from academic centers across the country is a more trustworthy source than maybe I don't know, whatever. I'll leave that as a more trustworthy source. So I think it's education and it's access, right? So, we send the screening, the mobile mammography unit, bus to the fair, to all parts of the town. I think that's a big part of it. I think community outreach is a big part of it. That's why, I try and go on, I do these like news interviews. I'm writing these like articles for different magazines, and trying to increase the awareness that, if you meet these criteria, you should get tested and we can make it affordable for you. It's not going to cost you $3,000, $4,000, $5,000. Even then, I don't think it's enough, right? It's still hard to, even motivate these patients. And a lot of times, maybe they don't want to know, right? They're African-American women are more likely to be diagnosed with more aggressive biology and later disease, exactly like you said. So we have to catch them before those things happen. And then certainly if you find a genetic abnormality, then you can screen the entire family and hopefully, give them preventative care well before a stage 4 diagnosis. So, community outreach is my short answer, but obviously this is a lot more complicated. I think educating on access not being something that is privileged or something that's going to have an insurance company down your back for the rest of your life is important. And, for me, like I said, it's reaching out to local news stations, magazines, community leaders, and trying to make a relationship there. So I'm, a year and a half in, and I'm still working on it. Give me a little more time and we'll see where I can take it.
Looking forward to it. Dr. Riley?
Thanks, Dr. Dong and Dr. Williams. Brian, from your own sort of experience, do you find what do you think the rate of family members testing after their family member has been found to have a genetic mutation? Because we do try to make it easy for them, and the testing companies try to make it easier for them. But in my own practice, it's an underutilized service. So what's your experience, and how do you think we can improve on that?
Yeah, absolutely. So, I think once we hired Meredith, there was a clear difference in improvement after that. Because truthfully, it is a lot to coordinate. Um, just on some of my high-risk patients, we've sent kits to uh, Caribbean countries, up in Canada, and also over to Europe. And as long as someone can get the saliva sample, the blood sample, and get a physician to sign up on the form, they will mail it back. And that's, if I'm being honest, I don't know all the details of coordinating that, but Meredith has been, integral to kind of forwarding that. So, the biggest issue is coordinating with multiple providers, not in Louisville, not in Kentucky, right? That's the hardest part. So I think it has definitely improved. I think if you leave it up to the genetics company, it will be missed. So there has to be someone appointed, which fortunately we have, right? So I've had pretty good experience so far. Hopefully stays that way. I think with our current situation, I've had, I have no complaints. It's been, I think, as efficient as it can be, with all these challenges.
And I think it's a good opportunity to reach out to those, on the Zoom today who do practice primary care across UofL Health, is that this might be, we might reach out to you to help assist if there are family members for whom you take care of, because one of the frustrating aspects of our job is when someone comes in diagnosed with advanced disease, and it was clear that this was a BRCA patient who's, could have easily been tested and intervened upon. So I think it really is a partnership amongst all types of physicians.
Yeah, absolutely. And that's the point I make with patients a lot, that, I see, I think I said this earlier too, I see all aspects, right? I see women that have no active disease. I see women with stage 4 disease, right? So my job is to educate you. My job is to show you what my, recommendations would be on a lot of these guidelines and slides I've shown you, and help the patient make the best decision they can. Some are going to be apprehensive of, doing too much and doing medications, and some are going to be very motivated to do, all the things. So what I would say is, I think there should be a very low threshold for someone to have a discussion with a high-risk clinic, whether it's me or someone at a different hospital system or in a different state or whatever. If you're deemed to not be too high a risk, then, it's just a one-off educational appointment. And then if you end up needing genetics, if you need more screening, certainly we can take over and help set those things up for you. So either way, I think it's a helpful discussion for patients, and that can, like you mentioned, Dr. Riley, it could potentially impact the rest of their family as well.
All right. If you have questions, you can unmute and ask, or if you want to put it in the chat area. And actually, there are two in the chat area. I'll go first from Dr. Laura Bishop, and then from Dr. Mark Pfeiffer. Dr. Bishop wants to know, says, interestingly, in Kentucky, the CDC reporting doesn't show Hispanic breast cancer data. Do we have any from our institution?
Yeah, so off the top of my head, I'm not sure, but with the Kentucky Cancer Registry and then with our own registry, I would imagine we do. So I can certainly reach out to our registrar and see, but off the top of my head, I don't know the exact number, but I believe we do follow that information.
All right, and a question from Dr. Pfeiffer. He says, at the other end of the spectrum from early age, high risk detection, at what age, if any, would genetic testing be of less value, 60, 70, or 80?
Right. So in patients without disease, if the family history still fits, I would just ask if there are, it could have implications for the rest of their family, right? Ideally, you test as close to the cancer history as possible. So if this patient is a grandmother to 3 kids who then have, 8 grandchildren, there may be a chance that the son or daughter qualify, but if you could test the grandmother, or sorry, the mother, but if you test the grandmother, then she may say, and she's negative, then you save testing for the whole rest of the tree, right? Whereas if there's something positive, well, then now we can qualify the rest of the tree to get tested. So, is there a cutoff where I would say we shouldn't? For the patient, yeah, maybe something between 75, 80 may not have as much benefit, but if they're the closest to the risk, then it could have absolute benefit for the rest of their family. So, it's a discussion, but just my default answer here. But I could easily see a situation where I would recommend genetic testing for even an 80, 90-year-old if they have an extensive family tree.
All right, thank you very much. And I say, we still have a few minutes. Any questions, feel free to unmute and ask, or again, you could type it in the chat area and we'll make sure Dr. Don sees it and hears it. I know, Dr. Williams, did you have a follow-up question? Look like you might have had a follow-up question there.
No, it's, just the thought, just trying to digest everything that I've learned today, and, the out-of-pocket $250, I just worry that things like that and the cost of genetic testing will actually, the genetic testing is helpful, but it is not equally applied to our population. It'll actually worsen healthcare disparities. So it's a great advancement. So let's see if we can't democratize it.
For sure. And, like I said, the majority of patients get covered and pay zero. And that's obviously our goal. So I don't know the exact details of the ones that had to get, that they had to pay, but usually it is depending on the insurance they have. You have to get this type of testing before you trigger this type of testing, or maybe someone was very motivated, but they didn't quite meet those criteria on that slide. So I would say I've had very good success with getting genetic testing covered in the year and a half or so that I've been doing it.
Great to hear.
All right, one more question. This is from Dr. Philip May, who is one of our community doctors and is a very, very frequent attendee to Grand Rounds for several years. He wants to know, are there any tailored diet/exercise program for women with obesity who are at high risk for breast cancer?
Yeah, so that's a great question. And I would tell you, our resource center has a lot of resources that truly are mostly dedicated for women with cancer. However, we have dietitians, and even one of our nurse practitioners, Whitney Pittman, also focuses in on exercise, diet, and things like that. So is there a specific program for them? I'm not sure. I don't think so. However, there are resources available where if I saw a patient that was very motivated, I think we could at least connect them to maybe a consultation more so, as opposed to like a 12-week program of a P90X or something like that. So definitely a great thought and something that we should probably look a little more into. But certainly an important focus for sure.
Well, along that line, yes, there was a Kaiser publication last year talking about dramatic improvement in recurrent breast cancer survival if people went on a vegan diet. I thought I was going to go an entire week without talking about vegan diet, but yeah, maybe next week.
All right, one last chance. Any questions or comments or anything?
Brian, this is Shahab Gafkazi. Just a comment. Excellent talk. So was just going to wanted to point out that we have some philanthropy money for coronary calcium score for our patients who are not able to afford that. Of course, that's not there's no company involved. It's just a simple CT scan. But oncology essentially tends to attract a lot more philanthropy money for some reason. I'm not sure. It's still cardiovascular disease is #1 killer, but I'm sort of straddling on both sides here, but I think I'm just making a suggestion. If for those patients who have to pay, maybe you guys may have access to philanthropy money to help them get that genetic testing done.
Yeah, so absolutely. I think it's hard to standardize that, but that is a resource that I think we just have to be careful how we use it, for this setting. So I've had more success with appealing to the genetics company and saying, in my opinion, they meet criteria because of, yada, yada, yada. But, it's a good point. So it's something we're mindful of, and it's still in process, I guess is what I would leave it at.
Sure, you're right. I mean, we use that sort of, it's our discretion. We just look at the patient and, get a feel that they can't afford it. And you're right. We don't really look deep into their financials and so on, see if they're lying to us or not. So we just trust them and go with that. So.
Yeah. Good to hear from you.
Well, all right. I think that probably wraps us up here. And Dr. Dong, thank you for an outstanding presentation. Dr. Riley, thank you for facilitating. And with Dr. Williams, Dr. Riley, will you guys have something you'd like to wrap up with here?
Just to say thank you, Dr. Dong. It's very informative. And I did send that link about the 20% reduction in and just with dietary intervention into the chat if people want to grab that. Dr. Riley?
Thanks, Dr. Dong. And again, if anyone has any questions, feel free to reach out to either of us via email. We're happy to navigate this for anybody.
All right. Well, the sun's coming out here, so which is nice. I guess that's a wrap for today. We'll be back next week, same time, September 29th at 8 a.m. Our hosting will be hosted by Division of Environmental Medicine, so we're looking forward to that. And Dr. Dong, if you can hang out just for a couple of minutes, we'll do the Cardinal Minute. Go ahead, Dr. Williams.
Yeah, actually, it was just going over what you were about to say about the Cardinal Minute. Just want to make sure that everybody knows that it's happening. I know we mentioned it, but maybe not everybody heard it. It's blowing up Twitter. And so please go on and watch the Cardinal Minute. We have our lectures on View Medi as well. And please spread the word around. If you can tweet or retweet about the Cardinal Minute. It's not the easiest thing to take your 60-minute lecture and turn it into 60 seconds, but they've been thoughtful so far, and we'll see. We'll enjoy Dr. Dong's version of it. It seems like people will listen to a 60-second grand rounds. Who would have thought?
It's the TikTok mindset. You know, if you can just splice it down, then they're good.
Exactly.
All right, everyone.
Okay.
Well,